so much for that introduction. Okay, let me share my screen. Let's see. Salam, could you just disable the or allow the screen sharing? Okay. Can you see my PowerPoint?
Yes, it's visible.
Okay, perfect. Okay. And so my name is Neal. I'm a pediatric epilepsy specialist. I live in Atlanta, Georgia, in the US. And today we're going to talk about epilepsy and developmental challenges and intellectual disability, kind of the interplay. And more importantly, what are the things that we can do when we're seeing patients to try to really, change the trajectory of their development. And so, this is a really big thing that we see that in general about in children with intellectual disability, 20 to 40% of them will have epilepsy. And it's really children who have a mild intellectual disability have lower rates of epilepsy, about 10%. Children with severe intellectual disability have over 50% of them have epilepsy. And then really it's we call kind of a bi-directional relationship in the sense of in children with epilepsy, about 20 to 50% of them will have an intellectual disability. So we'll talk a little bit about, what are some of the reasons for those high rates. All right, so what are neurodevelopmental disorders? These are a group of conditions resulting from a disruption in the brain's development that can lead to challenges in terms of cognition, movement, behavior, communication. And so when we're seeing a patient in clinic, we all, have a certain set of what we call developmental milestones, meaning at different ages as a child is growing, here's the things that I expect. And just because I, ideally expect them to meet a certain milestone, that doesn't mean I get, worried the moment they don't reach it. But, typically we allow a leeway of maybe about 3 months for them to catch up. But if they're, significantly delayed with their milestones, that's when we start to get concerned. So here's a list. For example, at 6 months, we might, ideally want them to sit with support, roll over both ways. They should be reaching and transferring, babbling, smiling. At 12 months, pulling to stand, have a pincer grasp, using 1 or 2 words. 18 months, walking independently, scribbling. They should at this point know about 10 to 25 words. They should point to show interest. 24 months, they should be able to run, kick a ball, combine words into short phrases. 3 years, they can copy a circle. They can use longer sentences, about 3-word sentences. About 75% of their words are able to be understood by a stranger. And then, so on and so forth. And so there are some, again, if you're about, 3 months with some of these earlier milestones, maybe 6 months with some of the later milestones, if they're delayed, that's when you start to get a little bit concerned. Some general red flags at any age. If a child is ever meeting, a milestone and then they have a regression or loss of milestones, that is abnormal. If they're not having any eye contact or social smile, they're not responding to their name or sounds, they have an abnormal tone, if they're too floppy or too stiff, or if they don't show any interest in people or play, these are abnormal at any age. So when we think about our patients with epilepsy, the factors that affect their development or can negatively affect their development, there's 3 different categories of factors. Number one, what is the cause of their seizures? We're going to talk about this in detail. But, in general, for most kids, the cause of their seizures, whether it's a brain injury, hypoxic injury at birth, an infection to their brain, this has caused some damage to their brain, which is now causing them to have abnormal development. There are certain causes of epilepsy that if we identify it, it can allow us to target our treatment so that we can affect the second option, which is the effects of seizures. We know that having repeated or prolonged seizures can affect brain development. Number 3, side effect of treatments. We know there are certain types of treatments that can have, more effect than others in terms of a child's development. We know all treatments have the possibility of affecting kids' cognition, behavior, mood, other types of things. So we're going to kind of touch on all 3 of these different topics. All right, so, number 1, when a patient comes into my clinic and they are having episodes that might be seizures, first question in my mind is, okay, am I convinced this is a seizure? Because there are a lot of things that can look like a seizure. And so I've, taken a good history. I've asked the appropriate, questions. I've done my exam. I'm convinced that this, sounds like an epileptic seizure. And it's not that the patient, fainted. It's not that the patient is having some type of, psychogenic or, some stress-induced kind of symptom. It's not that they're in sleep and having some type of a movement that's a normal movement. I'm convinced that they're having seizures. Second question in my mind is, well, do they have epilepsy? Well, for most kids, we make a diagnosis of epilepsy if they have two or more unprovoked seizures without, it's not that they had a person, took some drugs and they had a seizure. This is a seizure that happened, without a cause. Two or more unprovoked seizures, more than 24 hours apart. If I've made that diagnosis of epilepsy, and then it's the question as well, why do they have epilepsy? And epilepsy isn't a symptom. I mean, it's a symptom. It's not a single disease. There's a lot of different conditions that can share this final pathway of abnormal electrical activity in the brain, which causes seizures. So when I'm trying to figure out, what's causing it, in order to figure that out, I want to figure out, well, what kind of epilepsy is it? And so I have to figure out, okay, they're having seizures. What kinds of seizures are they? Are they focal seizures? Seizures coming from one part of the brain typically will be causing, focal symptoms. Oftentimes, seizure activity on one side of the body, or is it a generalized seizure, oftentimes causing, full body stiffening or shaking at the onset, or other types of symptoms. Based on that, then I can figure out what type of epilepsy do they have. They have focal seizures, then they have a focal epilepsy. If they have only generalized seizures, then a generalized epilepsy. And then sometimes we can see a combined epilepsy, or be not so sure. And then from that, I want to figure out, okay, what's the cause? A lot of different causes we're going to touch on. Do they fit into an epilepsy syndrome? And so in terms of the different types of causes, broadly speaking, we can break it down into what we call genetic causes, structural causes, and a lot of times, despite all of our different tests, we end up not really being able to identify a cause. So in terms of epilepsy syndrome, so an epilepsy syndrome is a characteristic combination of seizure types, age of onset, EEG patterns, and different developmental features, which often can be associated with a genetic or structural cause. And so, for example, if I have a patient that comes in, they're a 4-year-old and they have absence seizures, and I do an EEG and I confirm a typical pattern, well, then I can make a diagnosis that they have childhood absence epilepsy. And if I can make that diagnosis of an epilepsy syndrome, now I can provide really, really specific information about, what is going to be the most likely medicine to help, what percentage of kids might outgrow it or not outgrow it, and what type of other things to expect in terms of their development and other kinds of things. And so when we're talking about neurological development, there are a lot of different epilepsy syndromes, which characteristically can have a very severe effect on the neurological development, independent of just how many seizures they're having. So we know, again, seizures themselves, especially long ones, can cause brain injury, but there are certain epilepsy syndromes, which as part of the syndrome itself, we can see really marked effect on their development. And so again, as we're trying to figure out their epilepsy syndrome, we're thinking about, what age did they seizures start? What type of seizures are they having? And then what other types of things are we seeing? Are we seeing, again, what type of developmental changes are we seeing? Are there any other types of parts of their body that are, affected, like their muscles and other kinds of things? And so I'm going to go through a couple of the kind of most common epilepsy syndromes that I see that have really, really profound impact in terms of neurodevelopment. And if I go back, we see, and you guys especially, see a lot of children who have had, difficult deliveries, who have had, hypoxic injury to their brain. And so, we don't necessarily jump to try to fit them into a syndrome if we have a very clear cause for why they have epilepsy. They have some brain imaging that shows some severe brain injury, then we're not necessarily trying to jump to these causes. But if we have a patient and they don't kind of fit the typical history that we see, they haven't had a difficult, they started crying right after birth, they weren't born, they were born term, there's no family history, there's nothing that kind of explains why is this child so developmentally delayed. Why is this child having seizures? That's when we start to think about, well, is there a genetic cause? Do they fit into an epilepsy syndrome? And so we'll go again through some of the really kind of most common ones that we see. So first one I want to highlight is called early infantile developmental and epileptic encephalopathy. It has previously gone by a couple different names, but this is going to be a child who has their onset of epilepsy really very early in life, typically within the first 3 months of life, and they have very frequent seizures that are typically drug resistant. Abnormal exam, you're going to have, typically stiffness, difficulties with movement. You're going to have a very profound developmental impairment. You're going to have a very abnormal EEG, but they're not going to have a clear cause in terms of, they had a history of again, traumatic birth or something like that to cause it. When we do our testing, about 80% of the time, we're able to identify, with advanced genetic testing, the cause. But really, the types of seizures we can see a whole host of different kinds of seizures, things like tonic seizures, myoclonic seizures, epileptic spasms, focal seizures, and others. And so again, tonic seizures would be just, body stiffening, prolonged body stiffening. Myoclonic seizures, myo means muscle, clonic means shaking, so quick kind of muscle twitch. Epileptic spasms, which we're going to talk about in just a little bit. And then again, focal seizures. This is a different epilepsy syndrome, but I want to talk to you guys about a patient that I was able to kind of get involved with their care through CareEpilepsy. And so this is a patient who goes by Baby R, whose parents had, I think, reached out because she had started having seizures at about 3 or 4 months of age. And those seizures, despite a couple different treatments, became very, very difficult to get under control. And so I'm going to show a video of the type of seizures that we saw. And I've covered her face for privacy issues. And so what do we see in that video? So we see two seizures, one at the very beginning, one at the very end. It's a very kind of quick, arms kind of jerk up. It's a very stereotyped. The first one and the second one look kind of very similar. And we see it's happening in a cluster, meaning we're seeing kind of two of them back to back. So this is a very, very characteristic kind of seizure. It's called an epileptic spasm. And then this is another video of her again. Her face is covered. What parents have noticed is that, hey, this was a previously, pretty well behaved and happy kid, and they noticed a very significant change in terms of this kid's behavior and mood and sleep and other types of things. And so here's a little bit more about her history. And so she was born, she was diagnosed with meconium aspiration syndrome. She had a very, very kind of difficult first couple of weeks of life where she was critically ill and unconscious. There were no outward seizures seen, but she did have some episodes which, were maybe suspicious for seizure. Something that we see a lot in kids who have some type of hypoxic brain injury is that, when we hook them up to an EEG, we see that something like 30 to 50% of them are having some seizure activity on their brain waves that's not causing physical symptoms. So very, very, very common that kids in that kind of who have had some type of, neonatal brain injury, very, very common that they have some type of seizures. And so eventually, after about 3 weeks, she was discharged. She was on phenobarbital for a few months. Family hadn't seen any seizures. And then around 4 months, what family saw is these types of movements. So these kind of jerky movements. And along with that, what they saw is a very significant regression in terms of her development. So they saw a decline in terms of she was previously able to do all these different things, and now she lost all these. So she was previously able to track. She wasn't able to track. She wasn't vocalizing as much. She wasn't playing as much. She wasn't kind of holding her head up as much during tummy time. She wasn't interacting the same. and she was always irritable. And so again, they got a head CT. She had, signs that kind of fit with this diagnosis of some type of perinatal brain injury. And family kept very, very meticulous charting in terms of her seizures. At the beginning, she was having something like 200 of these spasms every day. They had initially tried phenobarbital, I think increasing it, maybe a little bit of response. They tried clonazepam, maybe a little bit more response, but was still having something like 100 seizures per day. And over these, couple months, still continued to have this significant impairment of her development. And so, this is an epilepsy syndrome, which we call infantile spasms, which is our most common epilepsy syndrome in infancy. I think if there's one thing to take away from, this talk, it's, the ability to recognize and treat infantile spasms is really one of the biggest things that we can do in terms of trying to help with um, children's development and their seizures. So it typically peaks at around 3 to 12 months of age, and they have a very, very characteristic kind of presentation. Very, classic kind of seizure like we saw, arms come up or kind of arms flex in very quickly, which we call a spasm. They have a very characteristic EEG finding, which I'll show you pictures of, but the other thing is that they have a developmental regression, that just like this baby, they're meeting a certain, trajectory, and then things start to backslide. It's very common that we see it in children like this child with structural brain abnormalities. And this is one where we want to diagnose it and treat it as quickly as possible, because the longer of a delay in terms of stopping these spasms, the worse that their seizures are going to be long term, and the worse that their development is going to be a long term. And so in my practice, when we get a call from another hospital saying, or from a pediatrician that says, hey, we have concern that a child is having infantile spasms, we will typically admit them to the hospital and start treatment right away. The first line treatment is, prednisolone or prednisone is a first line treatment that is, available in Ethiopia. And the response, so it's a type of seizure, a type of epilepsy syndrome that we treat very differently from other types of seizures. And with starting prednisolone, we see much, much, much higher rates of response compared to things like phenobarbital or clonazepam or other sort of common seizure medications. And so, what we saw with this child is that, family said that, okay, after we had started the medicine, pretty quickly within the first couple of days, they had noticed that she was more playful. She had a change in her facial expressions. She was kind of showing some of those kind of normal type of behaviors that she had been displaying previously before these seizures started. She was, prior to when she was having all these seizures, she wasn't able to feed properly. She was, choking on her food. They noticed that she was, okay, feeding better. They noticed an improvement in terms of her mood or cognition. In terms of her seizures, we did notice a significant drop in her seizures, but she still, I think, had, a couple spasms per day, but a really kind of, marked decrease. And, the question on my mind is, if we were able to kind of start our, we don't know what would have happened with her, but in another child, if we were able to start a treatment, very early of steroids, we might potentially have been able to, have a much even better response than what we saw with her. And so I'm going to show you guys a couple videos. So you see arms come up. So they can sometimes be very subtle, but again, this very kind of quick movement, usually either flexion or extension, tends to happen in clusters, oftentimes when kids are either waking up or falling asleep. A lot of times, can be misdiagnosed as, reflux or just a startle response or other kinds of things. So, and then in terms, I mentioned the EEG pattern, which I know that most people on this talk don't read EEG, but just for reference, this is a normal EEG, and then this is an EEG in a child with infantile spasms. And so, you can get a sense that brainwaves are completely out of control. And so it's no surprise that they're not really developing appropriately. All right. Another syndrome I want to mention because it's one of our more common genetic epilepsy syndromes that has a very profound developmental impact is Dravet syndrome. This is an epilepsy syndrome we see onset in the first year of life. Initially the description we're going to see is a child that might have seizures in the context of a fever. We might think because this is just febrile seizures. But then over time, we're going to see that they might have very prolonged seizures. They might eventually start to have them without a fever. And they can have these, very dramatic, either full body shaking or kind of hemiclonic, one-sided shaking seizures in a child who was previously kind of normally developing. They can have multiple different kinds of seizures, like myoclonic seizures, focal seizures, atypical absence seizures. And, as they get older, we start to see, oftentimes very profound effects in terms of their cognitive and behavior and also their movements. If we are able to get genetic testing, we see that there's one specific gene, which is called the SCN1A gene, which we see in, overwhelming majority of these kids. And, valproic acid is a really good kind of first-line treatment for Dravet syndrome. One of the challenges is that, these kids are having focal seizures, but really it's treating with some of our most common seizure medicines like phenytoin or carbamazepine, which are we call sodium channel blockers. These typically can increase the seizure frequency and severity, and treating with those medicines are strongly correlated with worse cognitive outcome and worse gait or worse kind of walking as they get older. So again, these patients present, with a really kind of oftentimes a pretty severe type of epilepsy in a previously normally developing kid, typically without any type of brain injury. So now you're kind of thinking, okay, this doesn't kind of really make sense for, there's not a clear cause. So now I'm thinking about, well, could there be a genetic cause? So this is a patient. Let me show you a video. So what you can see is this right hand has this kind of continuous, kind of very kind of low amplitude, very subtle kind of jerking. This is what we call a hemiclonic seizure. All right, so those are going to be some of the syndromes that we see kind of in very early kind of neonatal or adolescence or neonatal and kind of infants. This is what we're going to see in childhood. I'm going to go through a couple of the most common ones we see. One is epilepsy with myoclonic atonic seizures, previously called DEW syndrome. So this is going to be kids who present with new onset seizures, typically in the 2 to 6-year-old age range. This is going to be a kid who has a normal development and they have an explosive onset of typically a lot of different types of seizures. The classic one, it's in the name, is myoclonic atonic seizures, which I'm going to show you a video of, but they can have other kinds of seizures. And then their development is really going to be, plateauing or oftentimes regressing along with the seizures. Valproic acid and clonazepam are really good choices. But again, the key to kind of identifying some of these kids is, a kid with a ton of seizures who's previously developing. Again, you're in the back of your mind, you're thinking, well, why is this kid having seizures? And if you can't identify a cause, then could this be a genetic cause? And so what we can see is this child is eating, and then we can see there's this quick jerk, arms come up, and then they kind of atonic or they lose tone, and he falls back into the bed. All right. Another one that we see, one of our most common epilepsy syndromes, actually our most common epilepsy syndrome that we see in this sort of 3 to 5 year age range, so we call Lennox-Gastaut syndrome. This is going to be a child who may or may not have a history of some type of brain injury or brain abnormalities, who comes in at the typically around 3 to 5 with multiple different types of seizures, tonic seizures, atypical absence, atonic seizures, myoclonic seizures, a lot of different kind of seizures, and a very severe kind of at baseline, is pretty moderate to severe intellectual disability, who then has a regression. And these are going to be kids, different than the last one, where, these are typically normal developing kids who we can often get their seizures under control. Now, these are going to be kids who, typically have, lifelong epilepsy and a lifelong severe developmental disability. The last epilepsy syndrome that I'm going to talk about is we call developmental and epileptic encephalopathy with spike wave activation in sleep. So this is going to be kids who come in typically around 4 to 5 years old who have kind of very, oftentimes very mild seizures, but have had this very profound regression in terms of their cognition. Uh, and so, again, the way that they're presenting, it doesn't kind of make sense. Okay, we know that seizures can impact can impact development or can cause brain injury. But if you have a child, who's previously normally developing, who has very mild seizures or not that severe seizures, that they have a presentation that doesn't really fit with how bad their seizures are. And so what we see, and so this is a child who, had a neonatal stroke, and so at baseline, has some weakness and some issues. Here's his EEG when he's awake. You kind of take my word for it if you don't read EEG, that the left side looks a little bit slower than the right side. But then when he falls asleep, we see that the EEG gets very, very, very active. And so now this EEG has really, these findings, or this we call spike wave activation in sleep, it's not gotten to the point where it's completely affected the quality of his sleep. It's affected his ability to, form memories normally. It's affected the pretty much everything in terms of his thinking, his mood, his behavior, and other kinds of things. And if we can identify that, first line treatment, prednisone or high dose clonazepam, we can make a huge, huge impact and oftentimes get these kids back to a near normal or kind of just a mild impairment as opposed to where they were before. And so, it is, I know it is not always easy to get an EEG for our patients because EEGs can be expensive and they're not, widely available. And so we really want to think about using EEG, when things don't really make sense. So if we use an example of, say that we have a child who had a severe brain injury and they're having seizures, well, I don't really need an EEG in most situations to understand, that there's probably a lot of different parts of the brain that are at risk for seizures. And I don't need an EEG to help kind of guide my diagnosis because I might have, just based on the type of seizures they have, that the EEG is not going to really give me much information. But the EEG can be really helpful in a couple of situations. And this is one of those situations where things are not really making sense. The way they're presenting, it doesn't fit with, how bad their seizures are. It doesn't fit with their history. Then an EEG can be really helpful because if we can make a diagnosis like this, then we can, give them the correct treatment and we can really kind of improve their development. And so let's see. And so, finding a cause or putting them in an epilepsy syndrome, it doesn't just explain why the seizures happen, but it can sometimes help, guide our treatment because there are some types of syndromes or genes or genetic, epilepsies, which respond better to specific medicines or specific diets. So when we're thinking about, so we talked about sort of genetic epilepsy or kind of epilepsy syndromes, other type of, causes of epilepsy, about in my practice, about 30%, probably in Ethiopia, something like at least half of kids who come in with epilepsy, have some type of a structural cause. And we can think about structural causes in terms of congenital structural, meaning the way that their brain, developed, acquired structural, like things like hypoxic injury or stroke or bleed or other types of things. And then there are genetic structure, meaning there are certain genetic abnormalities which can lead to an abnormal structure in the brain. And so, here are just a couple different pictures of some different types of findings we can see in terms of that first category, which is that congenital structural, that as these children's brains were developing, we can see there's so many different ways, depending on the stage of brain development in which there was kind of some type of issue. There's so many different ways that we can see that these abnormalities in development. This is an example of tuberous sclerosis. Is something that we see somewhat frequently with kids who come in, and if we do imaging of their brain, we can see that they have all these, small little kind of we call tubers or kind of these overgrowths, and each of these little spots, are typically oftentimes can cause seizures. I'm not going to necessarily touch on, infectious causes of epilepsy because I think, you guys are much more experienced at treating that than I am. But autoimmune causes, these are, as you guys know, immune system purpose is to recognize and attack, infection. And autoimmune is when immune system can mistakenly start attacking healthy parts of the brain and cause what we call autoimmune encephalitis. And so again, this is going to be a child who was previously healthy, and they come in typically with acute onset, severe seizures, and we don't see any signs of infection, but we might have a history that they had some type of mild infection, a couple of weeks prior. But when we do our testing, it shows signs of inflammation. So here are some pictures of an autoimmune encephalitis, where you can see these areas that are kind of lighting up. These are areas where we're seeing inflammation. And then the final kind of subgroup. So again, we talked about genetic epilepsy, genetic causes of epilepsy, talked about structural causes of epilepsy. And then we talked about, and then this is kind of the third group, which is unknown causes of epilepsy. And so in my practice, up to 40% of the time, despite all of our tests, we're unable to really find a cause, despite doing EEG and MRI and, extensive genetic testing. And in terms of, while this can be frustrating for us as physicians or providers, it can be frustrating for families to not figure out a cause. But, more often than not, when we do find a cause, it tends not to be a great cause. And so children in which we don't actually find a cause, they tend to actually typically do the best in terms of their seizures and also in terms of their development. All right, so we talked a little bit about the different causes of seizures and how some of those different causes can help guide our expectations in terms of what their developmental trajectory can be. Other thing we want to think about is what is the effect of the seizures themselves? So we know that having repetitive or prolonged seizures can cause structural damage to the brain. I mean, that we have very, very, very good data for. We have a lot of data that shows, what type of timing that could be, that we've done a lot of studies where we induce seizures in animals, and then at different time points, we'll kill the animal, we'll open up their brain, we'll put it under a microscope, and we can tell that different types of seizures and different durations cause different amounts of damage. And so typically, with a full body seizure, typically takes about 30 minutes of continuous seizure activity to cause irreversible brain injury that we can see, under a microscope. And we also know that, having, shorter seizures, but that are happening, with a high frequency, these can also have, profound impacts in terms of brain growth and development. What we also know is that, outside of just the structural, damage from prolonged seizures, we know that there's physiologic damage or dysfunction from seizures that, after, say, a prolonged seizure, that, if I had a seizure affecting the right side of my body, for the next, say, 6 or 12 hours, I might have weakness on that side of my body. But the cognitive effects of a seizure, those can oftentimes last for days. And so when we have these kids that they're coming in and they might be having, 1 or 2 seizures a day, they might, just based on how frequent their seizures are, they might be having a pretty profound impact in terms of their attention and their learning and their behavior just for the aftermath of those seizures, independent of any type of damage or anything like that. So we know that, again, the seizures themselves can cause physiologic dysfunction. And so when a patient comes in, and this is actually something that, for those of you guys that work in the hospital itself, something that I really like to kind of highlight with every one of my talks is that, what we've seen is that, for every minute that we wait to treat a prolonged seizure, we're seeing irreversible brain injury. And so again, for those full body seizures, if a seizure lasts for 30 minutes, we're seeing irreversible brain injury. And the longer that we wait to try to treat that seizure, so typically we'll treat a seizure at 5 minutes if we're with an emergency medicine. Here we use things like Valium. Sometimes we use clonazepam or Ativan or midazolam or some type of benzodiazepine. We typically start at 5 minutes because we know that if we wait longer, the longer that we wait, the higher chance that this patient has that they're not going to respond to medicine, that the seizure is going to last long enough that it's going to cause irreversible brain injury. All right, so we talked about, how, the effects of seizures in terms of, damaging the brain, affecting cognition and learning and development. And so what can we do about that? Well, we can try to pick the right medicines and, get them to a point where we are managing their seizures, as best as possible. So these are, as last, I checked, these were the options that were available in Ethiopia. And so, in general, for generalized epilepsy, again, you're having generalized seizures, valproic acid is going to be a really good choice in most situations. Phenobarbital and diazepam also can be really good choices. And, I would typically avoid things like carbamazepine or phenytoin because they can sometimes make generalized seizures worse. For focal epilepsy, any of these options is going to be potentially a great choice. Typically for neonatal seizures, phenobarbital is going to be a really good choice. It works really well, and it has a really long kind of half-life. It stays in your system a long time. And so for neonates, they're typically metabolizing these medicines very quickly. And so this is a medicine that we can get and it can, get it to a good level and oftentimes works really well. But beyond that, most important thing in terms of getting their epilepsy under control is picking a medicine which they can actually get and afford. And so there was this great study in Addis where they found that about 55% of patients with epilepsy adhere to their medication regimen. And the biggest thing that they found is that, probably not surprisingly, is that 61% of them reported that they had trouble accessing or affording their seizure medicines. And so, patients who were able to access their seizure medicines were about twice as likely to actually take them. And so picking a medicine that they can actually get, is more important sometimes than actually picking like the best medicine. And so now we've picked a medicine. And okay, what are the effects of those seizure medicines? So, I mean, ideally, our goal for every seizure medicine, for every patient with seizures is, we want to control their seizures. We don't want them to have any side effects. And then we want to control what we call their comorbidities, things like their development, their mood, their learning, et cetera. And so we know that, anti-seizure medicines, they reduce the, irritability of our neurons, but they can also, reduce the excitability or kind of, they can impair your cognition, they can impair your attention and other types of things. Our biggest culprit would be phenobarbital, more so than carbamazepine or phenytoin or valproic acid. But typically, in my practice, for my patients who have seizures in that sort of neonatal period, again, phenobarbital is my go-to medicine. Typically around 6 months, if I can, I'm going to start talking about let's try to switch it to a different medicine. Even if it's working really well, they're not having seizures, I'm going to want to try to come off of phenobarbital and switch to another medicine if I think they're going to tolerate it. Because we have a lot of good data that shows that phenobarbital can really, impair brain development. It can cause kind of apoptosis or kind of death to some of our neurons. And so, in general, it's not going to be the best choice, just from a brain development or learning standpoint compared to some of our other seizure medications. There are a lot of children who, when we start a seizure medicine, they can show a significant change in terms of behavior and learning. Most of them, if we change their medicine, we can see an improvement in those side effects. We know that ADHD is far more common in children with epilepsy. A lot of people are afraid to kind of treat the ADHD with a fear that the treatment might worsen their epilepsy. But, in general, like typical treatments for ADHD, like a stimulant, if that's available, it's considered a safe option. So we use it a lot. And then the other thing, that is, you have maybe your older, teenage girls or some of your adults who are of childbearing age who are on valproic acid. Well, we know that children born to mothers who are taking valproic acid, have a pretty significant reduction in terms of their IQ and their development. Approximately 10 points of IQ reduction compared to children of mothers who are taking carbamazepine or lamotrigine or phenytoin. All right, so those are the things that I wanted to talk about. What questions do you guys have for me? Or comments if you guys have any additional experiences that you guys would like to share.
Neil, I think there are few questions on the chat.
Okay. Let me open the chat. Oh, let's see. Does any of the epilepsy syndromes have any associated imaging findings that could be expected? So yeah, so some of them do. So I'd say like the ones that have a really, really hallmark finding would be So let me go through our kind of our most common epilepsy syndromes. So of our really common ones, I would say there isn't any sort of really classic finding with prolonged seizures. There are, a couple hallmark findings that we see affecting, oftentimes the temporal lobes. The one that immediately came to mind is one called Rasmussen's encephalitis, which is an epilepsy syndrome that, we oftentimes see in the sort of 5 to 10 age range, which can characteristically cause a unilateral kind of atrophy of one side of the brain. And it's caused for reasons we don't completely understand. And really the only treatment for that, or the best treatment, is actually, cutting out that affected side of the brain. For any of our other ones, I mean, there are certain, genetic, or we call mitochondrial causes of epilepsy that can cause epilepsy syndromes, which will oftentimes affect some of our kind of deeper brain structures, like our basal ganglia. And so that's a great question. For a child with brain injury, HIE, and infantile spasms whose seizures have mostly faded, what improvements, cognitive and physical development, are realistically possible, and what limitations will likely remain? So that's a really good question. So in terms of infantile spasms, so the number one predictor of their outcome is going to be what's the cause of their infantile spasms. So if they had a severe brain injury at baseline and now they have infantile spasms, well, those kids are going to do worse regardless of whether or not they had infantile spasms. So they're going to have a really challenging outcome. We have a lot of kids with infantile spasms who have no clear etiology, even despite doing all our different genetic testing. Those kids tend to do the best. So there's that part of it in terms of the cause part of it. The second thing that we can control, again, how long the infantile spasms were going on for. So if they were going on for a couple of days, family identified it quickly, we got it treated, and then it subsided. Those kids have a much higher chance of having a good outcome. But in general, about a third of kids with infantile spasms, if well treated, about a third of them can, be expected to have sort of a mild developmental impairment, about a third moderate, and then about a third like pretty severe developmental impairment. And so, it is possible that a child with infantile spasms, might end up having a pretty good outcome. Again, if the cause is either not identified or something that's not a severe brain injury kind of cause, and then if we're treated, really quickly. All right, let's see. Children with especially cerebral palsy and epilepsy struggle with swallowing difficulties, which make it harder for them to take oral medications regularly. What are the best approaches or alternatives for managing epilepsy in such children? That's a really tough question. So, I mean, here we put in, feeding tubes for a lot of these kids, but I understand that that's not an option for a lot of kids in Ethiopia to have a feeding tube. Yeah, that's a really tough one. I mean, I think, yeah, unfortunately, I don't have a lot of experience with that question, so I'm not sure. But there are certain medicines that can dissolve orally, like be given like buccally, things like clonazepam, which can dissolve in the mouth, and that's an option. Medicines like valproic acid, I mean, in theory can be given rectally. I mean, it's not something we do frequently, but it does, there is data that we can use it rectally. I mean, that's hard to do on a twice a day basis, but that is an option. Okay, well, good. Well, thank you guys for your questions. Was there anything else? Okay, how can we manage neurodevelopmental disorders co-occurring with epilepsy at health centers? So that's a really good one. So, to a certain extent, it is trying to, figure out a way to keep them in school, because a lot of schools, the moment that they have a challenging child, they want to, even in my experience, they want the child to, not come into school, or to, have this very alternative type of schooling, which is not stimulating to them. And so, here there are laws that every school needs to be able to provide, what a child needs. And that might be extra time, that might be, extra support. And so, whatever is possible, advocating to schools, if you think they would be amenable, that, hey, this is what, this child will need extra time or extra support or this individualized plan to, support them in their learning. I think another thing is, controlling the things that we can control, which is, if their attention is not great, there are medicines that can help their attention. If they're not sleeping well, we have a lot of medicines, something simple like melatonin for a lot, or, can for a lot of parents, be a real game changer. If their behavior is out of control, that can be something. If we get their behavior under a little bit better control, then we can actually support them to go to school and actually start learning. But yeah, I mean, the biggest thing, again, controlling their seizures as best as we can, and then trying to make sure that we're not, in our treatments and in our medication, not really causing more damage to their development. What are clinical signs that help differentiate epileptic from non-epileptic events in children with developmental disorders? So that is a great, really, really good question. And actually, I'm going to, if you guys have a second, I'm going to share a slide from me. So actually, I don't need to share a slide. So this is a really good question because they can look very, very, very similar. So, when we say non-epileptic, that can mean a lot of different things. So there are many, many, many different causes of, body stiffening, shaking, changes in awareness. The most common ones that we'll see can be things like passing out, that when children or adults, when they faint, a lot of times their body can have, some stiffness or some body jerks that, for most of us, if we fainted, we would have some type of body movement. And when families or people see that, it can be mistaken for a seizure. A lot of children will have what we call psychogenic, non-epileptic seizures, I guess, in kids with developmental disorders that we still do see that, quite a bit. Where as a response to, whatever they're feeling internally, they might have episodes that look like seizures. A lot of kids, especially with autism, will come in with staring spells, and it can be very challenging because when we know that, epilepsy is much more common in children with autism, like something like 30% of them or so will have epilepsy. But also, staring spells is just part of, autism and the way that they kind of interact with the world. And so it can be very challenging to kind of distinguish between, what is maybe an absence seizure versus what is just a moment in which they're, trying to process things from a sensory way. So the biggest thing, that I advise people in terms of trying to differentiate between, an epileptic seizure versus all the other kind of, non-epileptic things that can look like seizures is, when someone is having a seizure, there's nothing you can do to get it to stop. It has to run its course. And so when a child is doing some type of a movement or a staring or something like that, I tell parents, really try to get their attention, in the hospital, we'll do a sternal rub, we'll squeeze their fingers, we'll pat them, see if we can get them to respond. Because if they're doing some type of a movement, they're staring, there's something, and you can get them to snap out of it with stimulating them, then that's very unlikely to be a seizure. So that's, number one. Number two, if family does happen to have a cell phone, if they can videotape, 5 seconds of the event and show it to you, and then a lot of times, when we see the video, that's a lot better than, just the description, because families, like, they don't really know how to describe these types of events in the way that, we can understand it. Or a lot of times these episodes might happen, say at school, and a teacher tells, the family who's now telling you, and by the time it comes to you, it's very hard to figure out, was it a seizure or was it something else? So this is something I do. Any ongoing studies that you are aware of that is being conducted to identify the causes of epileptic syndromes? So yeah, so that is so if I gave this talk, say like 10 years ago, we would have, a couple dozen genes that we know about that cause epilepsy. And, now, as of the last time I checked, there's about 900 genes that we know about that can cause epilepsy. And pretty much every month, we're discovering new genes. Now, of the, 20,000 genes that, we have, or that we know about that we have, about half of them, we have no idea what they do. And then of our entire DNA, 99% of it is our sort of non-coding DNA, which we have a very, very limited understanding of, what the function of that is, in response to that 1%, which is our coding DNA. So, this is a really, really exciting time for that. Any website or free resource that we develop our knowledge around neuroscience. In terms of epilepsy, I really, really like and recommend epilepsy.com. Really easy to remember. It has really, really good information on there. And everything that's like all the medical knowledge on there is prepared by epilepsy specialists and physicians. And so I think that's a really good one for anything epilepsy related. Welcome. All right. Well, good. Well, thank you guys so much for your questions and for joining. And again, if you guys have any more questions, and not knows how to get in touch with me, so just please feel free to reach out to her or Salam, and they can give you my information.